Hello guys, welcome to our channel. Today we are going to discuss about the Mission to 100 plus as part of our program. So today we are going to discuss about the important topics like ABG, EG, and also we are going to discuss about the diabetes mellitus and its overview. Okay, this is going to be around like 5 to 6 MCQs for sure in the examination. So very important. Please focus on these topics and very high yield topics. Okay, let's start the discussion. The first topic will be ABG analysis. So in the ABG analysis, my first question, what is the most common artery that is we are going to use? So the most common artery is brachial, followed by the radial and then femoral. Okay, these are the three arteries that we are going to use and get the sample of the ABG analysis. Next, coming to the indications. What are the common indications to do the patients, those who are having the ABG discrepancies? What are those conditions? Like most commonly in the ICU setting and patients those who are suffering from the COPD and respiratory diseases, okay, and also those who are with the shock, hypovolemic, hypovolemic, or the patients cardiogenic, neurogenic, we can also get, and patients those who are going for the transfusion and trauma care, okay, and also alcohol abuse patient, drug abuse, okay, poison intake patient we are going to see, diabetes mellitus, DKA patient also we are going to monitor, and in which patients it is contraindicated. So it is contraindicated LN test negative, okay, LN test negative. So what is mean by the LN test? Here you can see this is known as a modified LN test. So in the modified Allen test, we are going to compress the ulnar artery and also radial artery. And for the 15 seconds, we are going to remove the other side of the occluded artery. So then we are going to see is the perforator of the arteries is going to supply entire limb or not. But in case if it is not filling, then it is negative. Okay. If it is filling, then it is positive. And even though if it is not filling, then you are going to make the trauma that can cause the significant compromise and vascular ischemia is seen in this patient. So that's why we have to check before proceeding to the procedure. Next, moving on to the pH of the body. So what are the acidic factors that is present in our the body? So for example, CO2, which will be acidic in nature, and also H plus ions. Next, what are the basic in nature? That is HCO3, which will be in the basic in nature. What is the normal pH of our body, guys? 7.4, 7.35 to 7.45 will be the normal. Next, so if the pH is more than 7.4, then it is alkalosis. If the pH is 7.4, then it is acidosis. Okay. Next, we'll see the other values also. PCO2, which is normal, will be around 40 mmHg. Okay. And HCO3, which will be 24 24 milliequivalents. And PO2 will be 80 to 100 mmHg. Okay, remember this way, 4448. That way you can remember. Next, see here. So 7.4 is we consider the normal. If it is going to be decreased, then it is acidosis. If it is increased, it is alkalosis, right? This is known as a primary defect. Okay, primary defect of the ABG disorder. Let's see some of the examples. First, pH is low, that means it is acidosis. Next, HCO3 is also low, along with the PCO2 is low. So this is known for the metabolic condition, and metabolic, this is the primary defect, acidosis. Okay, next, coming to the pH, which is high, and HCO3 is also high, PCO2 is also high, then this is metabolic alkalosis. Primary defect is alkalosis, but respiratory is opposite. If the pH is low, then it is going to be increased. This is respiratory acidosis. Okay, same with the alkalosis, it will be always opposite to the pH, respiratory alkalosis. Okay, we'll see what are the causes. First, metabolic acidosis is divided by the anion gap. If the anion gap is high, then it is known as a hagma. Okay, if the anion gap is low, then it will be nagma. What are the examples for this? First, it is DKA and lactic acidosis, and patients those who are having the uremia and methyl glycol poisoning, and also salicylate poisoning. Next, nagma is going to be diarrhea, vipoma or RTA, and those who are taking the acetozolamide, and also patients those who are suffering from the other poisons. This is nagma. Next, some other examples for the metabolic alkalosis. Metabolic alkalosis. So what are the examples? Common one is the vomiting. Okay, so when they are vomiting, the HCl present in our stomach is going to wash out, causing the alkalosis. For this patient, the fluid should be given is NS. Okay, NS should be given. If you give the RL again lower the chloride, that will cause more hypochloria. So that's why you have to choose the NS for the choice. And other one is the loop diuretics, another cause, and aldosteronism. Next, respiratory acidosis, asthma, CNS depression, okay, and also emboli or obstruction, we can say. Next, respiratory alkalosis, which will be associated normally in the pregnancy and also seen in the anxiety, panic attacks, okay, panic attacks and sepsis, also pneumonia patients. Okay, these are the foundings for the respiratory alkalosis. Next, coming to the compensation. For the metabolic acidosis, it's always respiratory compensation. Acidosis, the acidic is going to be decreased. So what it is doing, whatever the present CO2 has to be washed out, right? So acidic condition is high, so it is washing out the CO2 by the hyperventilation. Next, alkalosis, acidic nature is not there here. So what it is doing, it is going to retain the CO2 by hypoventilating. And respiratory, the compensation is from the kidney. So this is the compensation. Let's learn how we are going to see the compensation factor first. So when I am talking about the compensation, how it is going to be for the respiratory, it is going to be from the metabolic. Okay, so vice versa, it is going to be. First, according to the Winter formula, we are going to see. First, metabolic acidosis, compensation, primary defect. Okay, how it is going to be changed. For example, metabolic acidosis, there will be decrease of CO2. Okay, for how much of the HCO3? For 1 HCO3, there is 1.3 of CO2 will be decreased. Next, metabolic alkalosis. Okay, again the CO2 has to be increased here. Okay, the CO2 has to be increased for every HCO3. For every 1 HCO3, there will be 0.7 times of increased CO2 will be seen. Okay, next, respiratory acidosis. It could be acute, it could be chronic. Next, respiratory alkalosis. This is respiratory alkalosis, acute or chronic. And here again, what is the primary defect, guys? PCO2, right? PCO2 will be the primary defect. For every PCO2, for every 1 PCO2 increase, there will be 0.1 HCO3 will be increased. Okay, and same with here. So if every PCO2 has to decrease, it is going to be compensated with the 0.2 HCO3 decrease. Okay, and how about here 1 PCO2 increase, it is going to be 0.4 HCO3 in the chronic phases. Okay, again here also 1 PCO2, when it is going to be increased, it is going to show how much, guys? There will be 0.4 HCO3 is going to be decreased. Okay, 0.4 times of the HCO3 will be decreased. All this will be accordingly to the Winter's formula. According to Winter's formula, here you can see this is how metabolic acidosis 1 HCO3 every 1.3 mmHg of PCO2 will be decreased. Metabolic alkalosis, for every 1 HCO3, 0.3 will be increased by the PCO2. Acute, 0.1 of the HCO3 will be increased. For the acute alkalosis, 0.2. 4 and 4 is common for the chronic types of the respiratory diseases. Right? Next, how can you interpret the differentiate the partial uncompensated or the fully compensated? Let's see the scenario. One patient, those who are admitted with the low pH and CO2 is also low, HCO3 is low. Okay, but when we are checked after 1 hour, CO2 is normal and HCO3 is low. Okay, then again after 3 hours, pH is decreased, CO2 is decreased, and again HCO3 is decreased. Next, after again 2 hours, pH is back to normal, CO2 is still decreased, and HCO3 is decreased. So what is the compensation we are going to understand here? So this is the condition of metabolic acidosis. All this condition will be metabolic acidosis only. And what happened to the compensation? Here, there is a compensation is going on. Okay, partial compensation is started. So when the metabolic acidosis, the CO2 is compensating. The value is decreased according to the Winter formula. So the partial compensation is seen. Next, here it is normal. So that means no compensation is started yet. Okay, no compensation are started or uncompensated, we can say. Next, here pH again, here it is partial compensation started. And pH is back to normal. The defect, metabolic defect is already gone. Then it is fully compensated. Okay, fully compensated. Next, moving on to the anion gap. Okay, anion gap is the formula with sodium minus sum of chloride plus HCO3. Okay, we are going to minus this whole value, and normal value is around 8 to 12 milliequivalents per liter. Okay, and if it is high, hagma, and if it is low, nagma. So again, first check the arterial pH. If it is less, then it is acidemia, and differentiate between the respiratory acidosis or the metabolic acidosis. And if it is metabolic acidosis, check the anion gap. If it is hagma, what are the examples? Ethylene glycol, lactic acidosis, DKA, or the salicylate. Next, normal anion gap, spironolactone, acidozolamide, diarrhea, renal tubular acidosis. Next, if it is respiratory acidosis, airway obstruction, chronic lung disease, opioids poisoning. So like again respiratory distress. Next, if it is more than pH, then it is alkalemia, respiratory alkalosis, hyperventilation, panic attacks, pregnancy patient. Next, metabolic alkalosis, it could be saline resistant or the saline responsive, vomitings, diuretics, and antacids. And again here Gentleman syndrome, hyperaldosteronism. These are the examples and overview of the our ABG diagnosis. Next, we are going to discuss about the diabetes mellitus. Diabetes mellitus is many causes. Okay, now we will. So let's have the discussion now on the diabetes mellitus. So when I say diabetes mellitus, it is not just about the type 1 or the type 2. So they are many causes. Okay. So from this elephant picture, I want to emphasize that there are multiple causes. Okay. It could be environmental, it could be genetic, it could be related to the autoimmune condition, or it could be destruction associated. So there are many types of diabetes related manifestations that are present. So before that, we have to understand what is the normal mechanism. So when you take the food, it is going to release the glucose into our body. So once they reach the liver, they are going to produce the glucose and they are going to store the glucose. Okay, and this cycle will be vicious. Next, once the glucose is released into the blood, what it will release? It is going to release the insulin. So what does the insulin will do? Insulin will open the beta cells and will help to take the glucose back to and utilization. For example, glucose utilization for the muscle, glucose utilization for the lipid tissue, glucose utilization for the brain. So the metabolical function will be occurred. Once the glucose is decreased, there will be increase of the glucagon. So glucagon will get back to the liver and produce the again glucose from the storage place. So this is how glucose metabolism works. But how this glucose will be uptake was done with the help of the beta cells. So this is your beta cell. Okay, this is your beta cell of the pancreas. So what happens here? How the insulin is released? So once you take the food in your stomach, so it is going to convert it as a glucose. So what does this glucose will do? It will reach the beta cells of the pancreas, and where there is a gate that is known as a glut, right? This glut will open the gate for the glucose. So it is going to convert, and glycolysis will happen, that is going to convert as a pyruvate. So mitochondria will produce the ATP, and when ATP is utilized, the ATP sensitive potassium channels is going to open. Okay, that opening of the potassium channels will cause the depolarization. Again, the calcium will be voltage gated calcium channels will open and will reach into the inside of the pancreatic beta cell. Okay, and there will be a second messenger. This second messenger will help to release the granules, and it will cause the these endovesicles of the insulin will release into the circulation, and this insulin will help for the muscle utilization, adipose tissue utilization, and brain utilization. Okay, this is how normal mechanism of insulin release from the body happens. Okay, now we'll see the what are the types of the diabetes mellitus. So the type 1, it is autoimmune condition. Okay, it is autoimmune condition. What happening here? There will be complete insulin destruction. Okay, complete insulin destruction. We can simply say there is complete absence of the pancreatic tissue, and that will be causing. And what is the most common autoimmune condition here? T cell plus B cell mediated. T cell plus B cell mediated, and this is type 4 hypersensitivity reaction. Next, type 2 diabetes mellitus. So this is acquired, and worldwide this is the most common type of the diabetes variant. And what happening here? There will be insulin resistance. Okay, there will be insulin resistance that is causing here. And highly these type 2 diabetes mellitus will be dependent and vary from the people those who are taking. Okay, it could be environmental, okay, or it could be genetic, and lifestyle changes is other cause. Next, we also have the type 3, type 1.5, or the type 1.5 LADA. Okay, this is known as a type 1.5 LADA. Okay, what does mean by this LADA? So this is known as a late autoimmune onset diabetes mellitus, onset diabetes mellitus in adult. Okay, so autoimmune condition, usually this is seen in the children. Okay, from the age group of the 10 to 11 years only seen, but this is late onset of autoimmune diabetes mellitus in the adult patients. Okay, usually this is a type 1 diabetes mellitus but manifesting as type 2 diabetes mellitus. Okay, this is a metaphor 1.5 diabetes mellitus. All right, next we have the MODI. So what is mean by this MODI? Maturity onset. Okay, maturity onset diabetes mellitus in young patients. Okay, in young patient. So there is a specific genetic defects that is going to cause, and there will be 5, 6, 7 like that. Many types of the MODIs will be present. In that, the most common will be MODI 3. This is the most common. This is due to defect of HNF hexokinase type of 1 alpha defect is going to cause this MODI. Okay, this is one other type. Next, we also have the type 3. We also have the type 3. This is going to be double or brain diabetes mellitus. Okay, brain diabetes mellitus, especially those who are suffering from the Alzheimer's, we are going to see this condition. Next, we also have the type 4 diabetes mellitus. This is seen in the elderly, especially more than 60 years of the age. Okay, and less symptoms. This patient will be less symptoms and less complications. Okay, next another type you all know, this is gestational diabetes mellitus, only associated with pregnancy. Only associated with the pregnancy. And this is going to be related to the type 2 diabetes mellitus physiologically. Okay, this is due to physiological. After pregnancy, it's going to be regress also. These are the types of diabetes mellitus. Okay, next we have to take note about the what is the criteria that we are going to use. So the three things that you have to take note. One is fasting blood sugar, and then HbA1c, and 2 hours postprandial blood glucose. These are the three important things that we have to take note. Okay, first we'll see those who are the pre-diabetics, who are the diabetic mellitus. So fasting blood sugar between the 5 to 6 to 6.9, it is considered as a pre-diabetic. So if it is more than 7 or 126 mg, then it is fasting blood sugar positive for the diabetes mellitus. Next, HbA1c 5.7 to 6.4, this is pre-diabetic, and if it is more than 6.5, it is considered as a diabetic. Next, 2 hours postprandial, then again it is 140 to 199, considered as a pre-diabetic. More than 200, considered as a diabetes mellitus. Then even we also have the RBS, random blood glucose levels. Even though if it is also more than 200 mg per dl, this is also considered as a diabetes mellitus patient. Okay. Next, what is this HbA1c? We will see important points about the HbA1c. So HbA1c is going to be the give the accurate values for us. So how? Because this HbA1c is known as a glycosylated hemoglobin. So every hemoglobin, it's how much is the half-life? 3 to 4 months, right? So when you do the HbA1c, which is glycosylated hemoglobin, it is going to give us the 3 months of the past 3 months of the values it is going to give. Okay, because this glycosylated hemoglobin will be containing of the beta chain. Okay, beta chain of the hemoglobin will be presented. So this is best to diagnose those who are patients, whether they're controlling in the past, even though it is for the prevention and it can be also for the diagnosis. We can use this glycosylated hemoglobin 1. Next, in some cases, this glycosylated hemoglobin can be false. Okay, false HbA1c. This false HbA1c is seen in the acute blood loss, and also those who are suffering from the chronic liver disease or the severe liver disease, and also pregnancy patients. Okay, this is also seen. And false HbA1c which is low. Okay, then some false elevations is also seen. False HbA1c which is elevated. So in which patients we are going to see this one? Those who are with the iron deficiency anemia, and those who are suffering from the renal failure, and also CKD patients, those who are on CKD patients, those who are on the dialysis. Okay, these conditions will be showing the false HbA1c raised, and these conditions for the false HbA1c lower value. Next, other investigations, what can be done for this patient? So one is fasting C-peptide levels. Fasting C-peptide levels. So why the C-peptide levels are important? So what is the C-peptide actually? So this is going to be the precursor of insulin. So we will get to know, is it due to type 1 or the type 2 diabetes mellitus, because C-peptide should be precursor of the insulin. If the C-peptide is completely absent, then it is considered as a type 1, right? It is going to be type 1. And if the C-peptide levels are going to be less, then it is type 2, right? So this will help us to divide between the type 1 or the type 2 diabetes mellitus. Next, other test. What are the other tests that we can do? We can go for the antibodies. Okay, and these antibodies, first most commonly we are going to see the GAD, and also anti-islets, and anti-mitochondria. Okay, so these are the types of the we are going to see in the patients. Okay, and also MODY related antibodies will be also seen. Okay, next moving on to the other, what is the important test that we can do? So this one is going to be glucagon stimulated C peptide test. Okay, in this glucagon C peptide test, it is best test. Okay, best ideal test. So why we are telling this is the best ideal test? We are actually testing the glucagon stimulated C-peptide. C-peptide is insulin precursor. So glucagon is going to stimulate the insulin and somatostatin. So that is how we are going to check this glucagon stimulated test. Okay. Next, how to interpret, guys? Sometimes, for example, if you see the C-peptide levels, okay, the C peptide levels are normal or decreased, but still the glucose is high. Okay, then it is considered as a type 2 diabetes mellitus. Okay, it is going to be type 2 diabetes mellitus. If the C peptide is absent, okay, but the glucose is high, then it is type 1 diabetes mellitus. Okay, this is how we are going to see. And C peptide is high along with the glucose is also, sorry, glucose is low. If the glucose is low, this is known as a insulinoma condition. Okay, this is known for the insulinoma conditions. Next, moving on to the therapy. So here you can see this is the insulin therapy. Okay, insulin therapy is given for the patients those who are suffering from the MODY and patients those who are suffering from the LADA and also those who are suffering from the type 1 diabetes mellitus. Okay, in the LADA we can go for the oral and also injectables, but type 1 and the MODY should be given because MODY is a genetic conditions we cannot change. Okay, that is how. Next, insulin have types, guys. So here you can see what are the indications for the insulin first. So before we start the insulin, majorly we are going to check HbA1c. So if the HbA1c more than 9.5% or equal to that, and patient is having the complication, okay, complications, especially micro complication, or there is a complication of the macro, and patient is having the DKA, and patient is suffering from the LADA. Okay, all these patients we are going to proceed. Okay, we are going to proceed for the insulin therapy only. Okay, first, what is the target when you are working on the insulin therapy? The HbA1c target is 7%. It should be maintained the 7%. Okay, next, moving on to here, these are the types. For the rapid insulin, you have the example Lispro, Aspart, Glucinate. For the short, regular insulin. For the intermediate, NPH. For the long one, it is going to be Detrimer. Okay, for the ultra long, there is also ultra long, that is going to be Glargine. Sorry, very long is going to be Glargine. Next, you also have the ultra long. You also have the ultra long. This is degludic. Okay, degludic. This is going to be the one. Next, whenever you see the patient, those who are suffering from the type 2 diabetes mellitus, let's look at the patient history. And you have to tell the patient going to start with the metformin, which is drug of the choice for your type 2 diabetes mellitus. Along with that, you have to tell the lifestyle modification. Again, reassess the HbA1c. If it is still elevated, then another drug should be added. And again, check the HbA1c after 6 months. Then if you see if it is more than 9.5%, then you have to start the insulin therapy. Okay, that is how we are going to start and assess the patient. Next, here you can see these are the oral hypoglycemic drugs. First, we have the classification of the Bigonides, this is the given the drug of the choice for the patients those who are suffering from the diabetes mellitus type 2. And what is the mechanism of action? It is going to decrease the hepatic glucose production and increases the insulin sensitivity. Side effects are B12 deficiency, GA upset, and lactic acidosis. Next, please don't give this drug if the patient is less than 30 mg per ml of GFRC. Okay, that is the first thing that you have to remember. Next, sulfonylureas. Examples are glimepiride and glimepiride. What it is going to do? We have seen the beta cell mechanism. So when the key channels are blocked, it is going to increase the more and more insulin sensitivity that is seen with the sulfonylureas. It is going to associated with the weight gain and hypoglycemia, and it should not be given in the patients those who are suffering from the heart disease. Next, meglitinides is same as the sulfonylureas. Examples are nuttiglinide and rapaglinide, and there will be less weight gain, less hypoglycemia will be seen. Next, DPP4 analogs, which will be end with the gliptons like saxagliptan, sitagliptan, they are going to inhibit DPP4 enzyme, which will increase the incretins, and the side effects are pancreatitis. Linagliptin is safe in the drugs those who are taking the renal failure, remaining all are going to be contraindicated, and they are good for the weight loss. Next, GLP agonist. This patient will be having same again incretins effect. When the incretins are indirectly increased, it will decrease the glucagon, increase the insulin, and decrease the satiety and increase the satiety and decrease the appetite. Again, pancreatitis is common because the DPP4 or the GLP-1, they are going to act in the intestines. Weight loss, the famous drug Ozempic is given. Next, terzepatide, it is common, can be asked, and these drugs, the dual GLP-1 and GIP is going to be the agonist for this terzepatide. Next, sitagliptin, sorry, canagliflozins and empagliflozins. The drugs are SGLT2 inhibitors. They are good for the heart failure patient, weight loss, but they are bad for the genital infections or the UTIs, and high risk for the decay also. And renal glucose reabsorption is seen with the SGLT2. Next, amylin analogs, the example is praamylitide. This is going to decrease the gastric emptying and suppress the glucagon, and commonly associated with the nausea and hypoglycemia. And this drug is subcutaneous. Next, alpha glucosidase inhibitors, oral drug, acaribos, maglitol, and these will also delay the intestinal carbohydrate absorption. Flatulence, diarrhea, and abdominal pain is seen. For the patients, those who are liver failure, renal failure, we should not be given. Next, thiazolidinodides, the pioglitazones and rosiglitazones. The glitazones are thiazolidinoids, and this will increase the insulin sensitivity from the PPAR gamma, and weight gain will be seen, high heart failure risk, but it is completely renal safe. You should not give the patients with the heart failure or the fracture risk, you should not be given. So this is the overall for the oral hypoglycemic classification. Next, moving on to the complications. Okay, first you see the complications such as it can be micro complications or it can be macro complications. What are the micro complications? Eye diseases such as retinopathy, neuropathy, and nephropathy. Micro, the whichever is, for example, eyes will be having the very small vessels. So eye disease, neuropathy, and nephropathy in the glomeruli is going to be microvascular. Next, macrovascular, coronary artery disease and peripheral artery disease, cerebrovascular disease, and also other diseases, gastrointestinal, genitourinary, dermatological, infections, cataracts, glaucoma, chiroarthrotherapy, periodontal diseases, and hearing losses. These are commonly seen with the diabetes related complications. Next, we have the two important complications that you have to take note. First, DKA, the diabetic ketoacidosis, and then we will be discussing about the hyperosmolar condition. Okay, let's see first what is the DKA and which patients the DKA will be mostly seen. So basically the DKA, the diabetic ketoacidosis, is seen in the patients those who are suffering from the type 1. Okay, type 1 patients will be having the more than the type 2 diabetes mellitus. Okay, next, what is happening in the DKA? usually the insulin is going to be deficient, right? This insulin is deficient, which will further increase the lipolysis for more and more the glucose intake. So what happens? There will be free fatty acids. Free fatty acids also going to increase. And in the counterpart, when the insulin is less, what happens? The liver is going to adapt and they are going to produce the more glycogen. So more glycogen, more lipolysis, and more pathway is going to increase. So once they reach more than 400 milligrams per dl, so the hyperglycemia is going to trigger the ketone bodies. Okay, so the ketone bodies in the body is going to produce. So these ketone bodies are known for the hydroxybutyrate, hydroxybutyrate. So this is the misnomer. It is not a ketone body, but it is the most common one. And also acetoacetate and acetone. Okay, this is responsible for the sweet smell in this patient. Okay, these are the effects that are going to be happen. So what happens here? There will be increase of the hyperglycemia, right? More than 400, and along with that, the patient will be having the glycosuria, because more and more glucose going to remove the water along with the glycosuria, and there will be increase of vomitings. Okay, and high anion gap metabolic acidosis will be seen here. So again, these patients will be having these many of the symptoms. So end of the day, what happens? If there is a risk, if it is not going to be decreased, this will cause most common cause of death in the patients with the cerebral edema. Okay, cerebral edema. Okay, it's a vicious cycle that is going to cause. Next, what is the treatment protocol for this patient? First, confirm the diagnosis and then only we have to proceed. So first, admit the patient in the hospital intensive care unit and assess the serum electrolytes, acid base status and renal function. Once that is done, replace the fluids. Okay, 10 to 20 ml per kg per hour should be given ringer lactate. Next, administer the short acting insulin IV and then IV infusion and increase the 2 to 3 fold if no response by 2 to 4 hours. Next, assess the patient what precipitated the episode. The most common cause also you have to take note. The most common cause will be infections. Okay, that is the most common cause for the infection. Next, another important thing is replacing the potassium. So if you don't replace the potassium but you corrected the glucose, then it will be going to cause the arrhythmias. So that's why replace the potassium. If it is less than 5.4 or less than 3.5, you have to really start the potassium, or else there will be detrimental of patient goal for the arrhythmias and death also. So this is the treatment protocol that we are going to use for the patients of the DKA. Okay, now we are going to discuss about the another condition, that is hyperglycemia hyperosmolar. This is hyperosmolar and hyperglycemic. So what is this condition, guys? Usually what happens, this is seen in the diabetes mellitus type 2, those who are elderly people. Okay, so relatively the insulin is low here. Okay, so what happens? Associated, like most common another factor, same again infection will be triggering here. So this uncontrolled glucose, how much it can be the dosage of this glucose? You more than 700 to 800 mg per dl. Okay, so that's why, and here the only effect is no lipolysis. Okay, no lipolysis is seen in this patient. So elderly patient with symptoms of lethargy, okay, confusion and coma. Okay, please consider the patient is having the hyperosmolar and the hyperglycemic condition. Okay, next cause of death for this patient is renal failure. Okay, and treatment protocol, It's not complicated as a DKA, but hydration is important and insulin it should be given for this patient. Okay, this is the importance of the conditions like micro and the macrovascular complications and the DK and the HHS. And let's continue with the ECG part. Here we are going to discuss about the all important topics, guys. So first, let's start with the basics. Okay, so we all know that there will be two different of the action potentials. For example, this is for the ventricle. Okay, so what are those phases, guys? This is the phase 4 and this is the phase 0. At the phase 0, there will be an influx of sodium, right? And here, this is the phase 2. In this phase 2, sorry, this is the phase 1. This is going to be your phase 1, and in the phase 1 the potassium is out. Okay, then this is going to be the plateau phase, phase 3. Why it is plateau? Because calcium is going to inside and again potassium is going to out, and here completely potassium is going to out, which will be causing the repolarization back to the stage. Okay, fourth stage it is going to happen. Next, here in the atrium, this is the phase 4 and this is the phase 0, and here it is phase 3. So in the phase 0 there will be a sodium influx, and here it is going to be the potassium efflux. Okay, again here going to be the potassium efflux. So there is no plateau phase that is present in the atria. Okay, this is the first thing that you have to remember about the action potentials. Next, moving on to here, what is the electrical conduction system? So first there will be a SA node which is known as a pacemaker, right? This pacemaker is going to send the signals to the AV node, right here. It is going to send the signal to AV node, and from the AV node through bundle of His, it is going to send to the right bundle branches and left bundle branches. So the route is clear here. It is first SA node, then it will send to the AV node, and through bundle of His, okay, and through bundle of His, it is going to send for the right bundle branches, and it is going to send for the left bundle branches, so that all the ventricles will be going to get this one. Next, moving on to the next slide. Here you can see this is how our whole pattern will be seen. First, what is the first step that is happening here? There will be a P wave. So the P wave significance. What is the P wave significance, guys? This is going to be the atrial depolarization. Okay, this is going to be atrial depolarization. Okay, next here there is a isoelectrical line. So this isoelectrical line is going to be your segment. This is PR segment. Okay, next here going to be the QRS complex. What is the significance of the QRS complex? It is going to be ventricular depolarization, right? It is going to be ventricular depolarization. Next, here it is again another isoelectrical line, ST segment. Okay, next here you can see this is the T wave. What is the significance of the T wave? Ventricular repolarization, right? Ventricular repolarization. Then whatever the atrial repolarization we didn't see, actually the here you can see this muscle structures whichever is present very bulky. So the QRS complex only going to show the ventricular depolarization. So the atrial repolarization is going to happen in the QRS complex only. But due to the muscle is bulk, it is going to be masked. Okay, first thing. Next, moving on to the next slide here. Here also we are going to see the same things. What are going to be here, guys? The waves, segments, and everything that you are going to see here. For example, what are the waves we have? P, Q, R, S, T. Okay, P wave is for the atrial depolarization. QRS complex is going to be for the ventricular depolarization. It is for the ventricular repolarization, right? Next, moving on to the PR segment and ST segment. These both are going to be the isoelectrical lines. Okay, isoelectrical lines. Next, what are the intervals? Intervals that are present are PR interval, RR interval, and QT interval. These three are going to be the intervals. Okay, and what is the paper size should be? So 25, okay, 25 mm per second is going to be the speed of the paper. Okay, this is the basic forms that you have to understand. Next, coming to the here, what are the leads, guys? So first, ECG have 12 leads. Okay, so what are those 12 leads? For example, ECG is going to be 12 lead ECG. Okay, it is divided into the unipolar and it is divided into the bipolar. Okay, bipolar leads are 1, 2, 3. Okay, next there will be a leads of unipolar subdivided into the augmented and precordial. Okay, so these augmented are going to be AVF, AVR and AVL. So these are going to be the chest leads V1 to V6. These are going to be your chest leads, and these chest leads are going to be horizontal right, and remaining all are going to be vertical lines. Next, this is triangle of Einthoven, the first discover of the ECG. So this is known as a Einthoven triangle. So what he said that the lead 1 and lead 2 and lead 3 will be interlinked. How? The lead 1 plus lead 3 is going to be equal to lead 2. This is the formula that he has said for the Einthoven triangle. Next, this triangle augmented leads was given by the Goldberger. Okay, Goldberger scientist, he has said that this is the invention for the put also. We can get the leads and their action of the heart we can see. Okay, electrical conduction can be seen for this patient. Next, here you can see these are the chest leads. So chest leads, where is the location? This two is going to see the lateral side, right? These two is going to see the lateral side, and here it is going to be on the right side of the segment, right? This is going to be on the right segment, and here all these are going to be on the left. So it is looking like anterior and septal. Okay, anterior septal that we are going to look. Next, IVF is going to be inferior, and again 1 and 3, this is going to be lateral. Okay, this is also anterior. We are going to see of the heart in the different camera looks. Okay, next here also here you can see this is the normal ECG, guys. Okay, in this normal ECG we are going to see what is the first thing that you have to take note. What is the size of the box? Okay, one box, this one small box. Okay, this one small box, how many seconds? 0.04 seconds is going to be. And what is the amplitude? So the amplitude of this one is 1 mm, which is equal to 0.1 mv amplitude. Okay, this is how. Then if this all into the big box, okay, this one big whole box is how much then? This one big whole box is going to be 0.20 seconds. Okay, sum of the all 0.04 second. Okay, this is for the small one and this is for the entire big one. Right, this is how we are going to calculate the each and every part of the ECG with this measurements. Next, see the P wave atrial depolarization. Right, P wave is going to tell us two important factors. Okay, if you see the P wave is normally less than 2.5 mm in the lead 2 that we are going to see. Okay, and if the P wave is absent, then it is considered as a atrial fibrillation, and sawtooth P wave like this P wave is going to be seen, that is atrial flutter. And if the P wave is highly peaked, then it is considered as a right atrial enlargement seen in the cor pulmonale of the COPD, and notch or the bifid that is seen in the mitral stenosis, and inverted is seen in the ectopics. Next, PR interval and the AV node dysfunction. In the PR interval and the AV node conduction time, you have the important factors. For example, if it is prolonged, so that what is it is signifying that it is due to AV block. So the conduction is problem from P wave to AV node, there will be a conduction. Next, PR less than, if it is less than, then it is lag is due to, again there is a dysfunction that is present is seen in the WPV syndrome or Lorne-Gognock syndrome. So this is also due to which conditions, guys? Ectopic. Okay, there will be ectopics that is present, that is causing early or very short time of the PR interval is seen. What is the normal? 0.12 to 0.20 seconds. Next, here you can see the normal and abnormal heart rate. How we are going to calculate the normal and abnormal heart rate? So if it is more than 120, it is fast heart rate. If it is less than 60, it is slow heart rate. So let's see first how we are going to calculate. What are the going to be the formulas here? First, there is a first formula that is known for the 300 divided by big squares. 300 divided by big squares. Okay, this is how we are going to calculate for the heart rate. Next, second formula. Here the second formula, 1500 divided by small squares. Next, what if it is only the regular RR interval? Then only we can use the 300 big squares or the 1500 small squares. What if there is a abnormal rhythm? Then for abnormal rhythm, we are going to have the other calculation also. What is that? The number of QRS complexes, the number of QRS complexes in 30 large boxes, in the 30 large boxes into 10. Okay, into 10 we are going to see. So this is how we are going to calculate the heart rate. Here you can see the 300 big boxes, 1 2 3 4. So divided by 4, it is going to be 75 beats per minute. Next, here you can see the small boxes, 1500. Then these all small boxes we are going to check in the RR interval. Then again here it is going to be 55 beats. So this is where we can check the heart rates. Next, moving on to the axis deviation. What is the normal axis deviation, guys? Here you can see the minus 30 degrees to 110 plus degrees is going to be the normal axis deviation of our heart. Then how can we calculate? With the thumb module. Okay, with the thumb rule. So if this is your right side of the thumb. Okay, this is your right side of the thumb and this is your left side of the thumb. Okay, if both the thumbs are positive, then it is normal axis deviation. And if your lead one and right thumb is positive, then it is likely to be left axis deviation. And if you are sorry, so this way. First, this is your left side and this is your right side. If both are positive, guys, this is going to be normal axis deviation. If your left side is only positive, then it is left axis deviation. And if it is your right side of the thumb is positive, then it is right axis deviation. Where this positive you are going to see, this positive is like this positive wave that you are going to check. Okay, every wave is going to be positive, then it is considered as a lead 1 and lead AVF that we have to check. Okay. Next, moving on to, we are going to discuss about the bradyarrhythmias. What are the examples of the bradyarrhythmias, guys? The sinus bradycardia, sick sinus syndrome, and heart blocks. First, sinus bradycardia. So what is meant by the sinus bradycardia and which patients we are going to see this one? So sinus bradycardia, the heart rate is less than 60 beats per minute. Okay, heart rate is less than 60 beats per minute. In which patients this is commonly seen? It is seen in the athletes, okay, athletes, and also those who are suffering from the febrile illness of the fever. And what is the treatment? Treat the underlying cause. Okay, treat the underlying cause. And IV atropine is given if there is a severe bradycardia and patient is loss of consciousness, pulselessness, then we can proceed for this patient treatment with the IV atropine. Okay, sinus bradycardia. Next, moving on to the sick sinus syndrome. What is the sick sinus syndrome? Sick sinus syndrome is going to be tachybrady syndrome. Okay, this is tachycardia and this is bradycardia, right? So the tachy and brady is seen together, then this is considered as a sick sinus syndrome. What is the most common cause for this one? Endocrinopathies. Okay, endocrinopathy is the most common cause for this patient. And treatment, you should not give. Contraindication is beta blockers. Okay, treat the cause. Treat the cause, eventually it is going to be decreased. Next, moving on to the first degree heart block. So in the first degree heart block, what is the significant thing that you have to understand? The first degree heart block, there is going to be one P wave for every QRS complexes, but PR interval is going to be prolonged. Okay, the PR interval is going to be prolonged here. Okay, only the thing is PR interval is prolonged. Right? This is seen in the first degree of the heart block, and treatment is supportive. Next, moving on to the second degree heart block, and this is Mobitz type 1 and Venke back. Okay, what does mean by it? So there will be PR interval prolongation. There will be PR interval prolonging over the time. Okay, so suddenly there will be P wave drop. Okay, P wave drop will be seen. So PR interval prolong and P wave drop, sorry, QRS complex here. There is a QRS complex drop that is seen in the second degree heart block or the Mobitz type 1. Next, second degree heart block, Mobitz type 2. What happened here? There is no PR interval prolongation. Okay, no PR interval prolongation, but still there is a QRS complex drop. Okay, there is a QRS complex drop. This is Mobitz type 2. Okay, this is known as a Mobitz type 2. Next, third degree heart block, it is going to be complete heart block. What happens? There is discrepancy. P wave is going to be different and QRS complex is also going to be different. So this patient treatment need the pacemaker. Okay, pacemaker is needed for this patient. Same as this patient, the treatment for this patient is the pacemaker. Okay, this is how we are going to treat these conditions. Next, moving on to the tachyarrhythmias. How we are going to classify the tachyarrhythmias, guys? Let's see here. So, first, whenever you are going to see the tachyarrhythmias, please check the QRS complex. Okay, if the QRS complex is less than 120 seconds, if the QRS complex is less than 120 milliseconds, that means it's narrow. Okay, if the QRS complex is more than 120 seconds, 120 milliseconds, it is wider. Okay, then what are the causes? First, if it is wider, it could be ventricular fibrillation or ventricular tachycardia. Next, if it is narrow, then you have to look for the P waves. If the P waves are present, then it is sinus tachycardia or atrial tachycardia. Okay, and atrial tachycardia examples are going to be atrial flutter and MAT, multi-atrial tachycardia, that you are going to see. Next, if the P wave is absent, P wave is absent, then it is SVT, supraventricular tachycardia or atrial fibrillation. Atrial fibrillation. So this is how we are going to classify the classification between the tachyarrhythmias. Now we will be discussing the main difference between the sinus tachycardia and the atrial tachycardia. So let's see which is most common, guys. Overall, the most common will be the sinus tachycardia is going to be most common. Next, what is the difference between this? Sinus tachycardia is going to have the narrow QRS complex same as the atrial tachycardia, narrow QRS complex. Okay, first, and then P and QRS going to be equal with the sinus tachycardia, whereas atrial tachycardia more with the P waves rather than the QRS complex equality. So what is the treatment? Supportive treatment, and please treat the underlying cause for this patient. Next, they are the causes: atrial flutter and multi-atrial tachycardia. These are the other types we have to treat. So first one, atrial fibrillation. So this atrial fibrillation is known for most common sustained tachycardia, most common sustained arrhythmia, and most common overall also. What is the defect here? CA. This is QRS and T. Okay, QRS T, but there is P wave absence. Okay, P wave is absent, right? So these atrial fibrillation will be associated with the risk of clot formation, and if the clot will be circulated, it can cause the cerebrovascular accident or it can cause the embolism. Okay, to prevent that, we have to treat accordingly this arrhythmia. How we are going to proceed? First of all, you have to check is the patient is stable or unstable. Okay, based on this, we are going to treat. If the patient is stable, please go for the screening echo. Okay, echo should be done for this patient. And if you see echo is positive, then start the patient on dual antiplatelets, and then you have to start the patient on the amiodarone. But if the patient is unstable, then you have to go for the cardioversion. Cardioversion should be given for this patient. So this is how we are going to treat the atrial fibrillation. Next, here you are going to see the atrial flutter, and in this atrial flutter also you are going to see the sinus pathway. Okay, sine tooth pathway, sine wave, or the sawtooth appearance. Okay, this is how we are going to see. This is the example of atrial tachycardia, right? And these patients, to this arrhythmia also same again. Is the patient is stable, hemodynamically stable, then we can go for the beta blockers to decrease the heart rate. Okay, then those the patients less than 90/60 and unstable, then we have to go for the cardioversion for this patient also. Okay, next. Moving on to the paroxysmal supraventricular tachycardia. These paroxysmal supraventricular tachycardia is most commonly, this is most commonly seen in the children. Okay, childhood patients we are going to see. So again here also P wave is absent, but the difference between the atrial fibrillation and paroxysmal supraventricular tachycardia is it regular rhythm. Okay, it is going to be regular rhythm. That is the main difference here. So again, if you see there is a stability of the vitals, then you can go for the IV adenosine. Okay, IV adenosine should be given rapidly. Why I was telling it is should be given the rapidly? Because its half-life is 10 seconds only, less than 10 seconds only. That's why the drug of the choice adenosine should be given rapidly. But if the patient is asthma and patient vitals are stable, then you can go for the verapamil as a drug of the choice, okay, for the asthma patient. But again, if the patient is unstable, then go for the cardioversion. Okay, this is done for these patients. Next, moving on to the multifocal atrial tachycardia. So what should be done for the multifocal atrial tachycardia? This is commonly seen in the patients of the COPD or patients those who are suffering from the theophylline toxicity. So there are three different morphology of the P waves. Okay, there are three different. Here you can see this is different, and here this is the bifid, and this is the inverted. This is going to be notched. So the three different atrial tachycardia which will be seen with the three different P wave morphology, that is known as a multifocal atrial tachycardia. Again, if the patient is stable, treat the underlying cause, give the beta blockers. But if the patient is unstable, then go for the cardioversion. Okay, cardioversion should be done for this patient. Next, ventricular tachycardia. In this ventricular tachycardia, what we say, this is going to be the white QRS complex, and this is going to be more than 250 beats per minute. Okay, it is going to be very high. So what we have to do for this patient is we have to see is this patient is having the how the presentation is seen. For example, ventricular tachycardia, the patient is pulse is present and patient is stable, then you can go and choose the amiodarone. But if you see the patient VT but pulselessness, okay, pulselessness, vitals are unstable, then you have to go for the defibrillator. This is done for this patient. Okay, this is how we are going to do. And even though if it is there, the patient VT is not VT is seen, and then pulse is present, patient is unstable, then you have to go for the cardioversion. Okay. If everything is abnormal only, then only we are going to go for the defibrillator for saving this patient. Next, ventricular fibrillation. In this ventricular fibrillation, you can see it is completely disorganized pattern, right? This is going to be disorganized pattern. So regardless vitals are stable or not, okay, vitals stable or unstable, you have to go for the defibrillator. Okay, defibrillation should be done for this patient. Next, torsades de pointus. So torsades de pointus is due to what condition, guys? Usually the torsades de pointus is due to complication. What complication? It is due to QT prolongation. Okay, QT interval prolongation, which will be causing this condition, right? This kind of pattern that you are going to see in the torsades de pointus. So they are going to be the causes. First, anti-arrhythmic drugs class 1A, class 1C, and class 3. Okay, next, B for antibiotics, for example, azithromycin, fluoroquinolones, and C for antipsychotics, clozapine. These drugs can be also seen, and there will be other drugs also, such as domperidone, okay, domperidone or the SSRIs. These drugs is also going to cause this torsades de pointus. What is the drug of the choice for this patient? MGS44. IV MGS44 is given for this patient. Next, Wolff Parkinson White Heart syndrome. In this, there will be a ectopic, right? Here you can see there is a bundle of Kent. Okay, there will be bundle of Kent. Here you can see this is the extra, or we can say this electrical signal is going to cause this condition. So what are the ECG findings that you are going to see in this condition? Here you can see there is the early or the short PR interval. So there will be short PR interval, and along with that you are going to see the delta wave. What is the treatment? Ablation. And drug of the choice, you can give the prokinamide. Prokinamide can be given for the treatment of this patient. Okay, next, moving on to the Lorne-Gognon-Levine syndrome. So what is this Lorne-Gognon syndrome? Usually what happens, what is the difference between this condition is same, there will be a ectopic waves, but these ectopic waves is not going to be the bundle of Kent, but it is coming from the other side of the atrial only. We are going to see this condition. So what happens here, there will be also PR interval which is short, but no delta wave. Okay, no delta wave. Okay, there is no separate bundle of Kent, but other ectopic beats that is coming, and treatment is supportive and ablation. Ablation is done for this patient. Next, moving on to the U wave. Okay, so here you can see this is the U wave, P, Q, R, S, T, and U wave. Okay, here you are seeing the U wave. So what is the significance of the U wave? Usually this is considered as a normal condition. Okay, it is seen with the papillary, contraction, and also late ventricular repolarization. Okay, first thing that you have to remember. But it can be seen in the abnormal also. For example, it is seen in the low potassium, low magnesium, okay, and hypothermia. These conditions, it is also seen in the patients of this low potassium, low magnesium, low hypothermia. And what is the treatment? Supportive. Okay, supportive treatment is given for this patient. Next, moving on to the J point. What is the significance of the J point? It is a junctional point. Okay, it is a junctional points between the here you can see this is the junctional point. If it is point that is raised, this is going to signifies the ST segment elevation, and ST segment depression. Okay, that is how the junctional point that is going to decide from this. Next, here you can see this is the Osborn waves. Okay, this is known as a Osborn waves, and these Osborn waves is not considered as a ST elevations. They are not ST elevation MI. Okay, first point that you have to take note. And what is the most common cause then? The most common cause for this one will be the hypothermia. Hypothermia is the most common cause for the patients, those who are suffering from the Osborn waves. Next, hypokalemia differences and the hyperkalemia differences. What are the differences that you have to remember, guys? First, hypokalemia is associated with the tall tall T waves, okay, and ST elevation. Here you can see T waves are tall and ST elevation. Next, QRS complexes will be broad and PR prolongation. Okay, that is also seen. Sorry guys, here the correction you have to make note. Here this is hyper. Okay, this is hyper, this is hypo. This is hypo. Next, in the hypokalemia, the T wave is flattened. The T wave is flattened and depression can be also seen. And U wave is positive, right? QT and PR is going to be prolonged. And what is the treatment of the choice? Calcium gluconate. Calcium gluconate is given for this patient. Here the treatment will be KCL. Next, hypocalcemia. Always remember that the calcium is going to be friendly with the QT, okay, or directly proportional. So if the calcium is decreased, QT prolongation will be seen. If the calcium is raised, then QT depression will be seen. Okay, what is the risk? It is associated with the torsades de pointus, right? Torsades de pointus, if there is a more QT interval, and no torsades will be seen with the hypercalcemia. Next, digoxin toxicity. In the digoxin toxicity, what you are going to see, what are the findings? What is the main mechanism of the digoxin toxicity? So the patients, those who are giving the digoxin toxicity, it is going to block the sodium, potassium, ATPase. Okay, it is going to block. When they are blocked, what happens? There will be increased sodium in the myocyte, which will be causing the calcium, and the sodium exchanger will be decreased. So over the time, what happens? This calcium is going to build inside that, and there will be regression and complete contraction will be increased in the digoxin toxicity. So what are the findings that you are going to see specifically? Here you can see this is known as a sluggish. So this scoop ST depression, which is also known as a Salvar slog, and T wave inversion, right? Here you can see T wave inversion and PR prolongation. PR prolongation will be seen here. QT interval is also going to be decreased here. The next, next. Next, we are going to see here ST elevation. Okay, this is the classical picture of the MI, right? And in the MI, we are going to see the differences. First, is it ST segment elevation from the J point? Okay, as I said, this is the junction, right? From the J junction, it has to be elevated. Then only we consider this as a ST elevation. So here you can see this is a classical picture of the ST elevation. And this is non-ST elevations like ST depression or the T wave depression. And how much it has to be? The ST depression, if you see those in the chest leads, it should be more than or equal to 2 millivolts or 2 mm. And in the limb leads, it should be more than 1 MV or 1 mm. It has to be seen. Next, what is the treatment protocol that we follow for the patients of the STMI? So for the STEMI patients, you have the PCI intervention less than 90 minutes for the door to balloon time. If it is non-PCI center, then it should be 120 minutes to give the patient the PCI intervention percutaneous coronary intervention should be done for this patient. Okay, and if they are non-STEMI, okay, if they are non-STEMI and severe condition, then again PCI should be done less than 120 minutes. If it is moderate, thrombolysis should be done. Thrombolysis should be done for this patient. Next, here you can see this is the picture how we are going to see what are the leads are involved. Let's see. So this is the heart circulation, guys. Predominantly on the anterior side, you have the two arteries, right coronary artery, left coronary artery. What are the right coronary artery going to supply? See here, SA node, AV node is going to supplied by the right coronary artery, and right atrium is supplied, and also here right marginal artery will be supplied. So most of the hearts will be right dominant. Okay, it is going to be right dominant only. So predominantly they are supplied by the right coronary artery, and left coronary artery on the anterior they have the circumflex branch and also anterior interventricular branch, and posterior interventricular branch is again branch of the RCA. Okay, and what is the most common artery that is involved here? The most common artery is this one. Okay, the LADA, left anterior descending artery, is the most common artery involved in the MI. Okay, next, what is the interpretation here? So based on the interpretation here, we can see whichever the parsi leads is involved, that is going to show us the infraction. Okay, let's see what are those. For example, if you see the lateral leads, what are the lateral leads, guys? V5, V6, AVL, and first lead. These all are going to be on the lateral side. What is the artery that is involved? Left circumflex artery. Okay, left circumflex artery. Here you can see this is the left circumflex artery on the lateral side, right? Next, inferior, 2, 3, and foot, right? AVF. So what is the artery that is involved? RCA. Here you can see RCA is going to be in the foot inferior region, right? Next, septal. So on the septal, it is going to be V1, V2. On anterior region, it is V3 and V4. For this both, it is going to be predominantly LADA. Right here you can see this is how the LADA is going to supply anterior view. Okay, so here you can see this is how we are going to interpret. So lateral is going to be the LCA. Okay, and inferior is going to be RCA. Again, lateral is going to be LCA. This is going to be LADA. You have to find out from the arteries and their waves. Next, here you can see another picture. The broad, complete, diffusely, you are going to see all the leads are going to be involved here as a ST elevation. So this diffuse ST elevation is seen in the condition of the pericarditis. Okay, so the pericarditis patient is going to have all the ST depressions will be seen in these conditions. So how you have to understand, in the stage 1 it is going to be PR depression, and in the stage 2 there will be transitional change, and in the stage 3 it is going to be the T wave inversion and normalization of the ECG. Okay, so the stage 1 you are going to see the findings during the acute stage, PR depression, ST elevation, and in the fourth stage the normalization will be seen, and in the T wave inversion is seen in the stage 3. Okay, next we are going to discuss about the MI markers here on the short note. The MI markers, what is the first MI markers to be elevated, guys? That is ischemia. It is ischemia modified albumin is the early. Okay, then if it is not given in the option, then go to choose for the heart fatty acid. Heart fatty acid you can choose. If these both are not given, then less than 2 hours it is going to be myoglobin. Okay, less than 6 hours to 7 days, and this is the specific one. Also for the re-infarct, this is drop. Okay, drop high you have to choose. And next 24 hours, CKMB and also LDH. This is going to be positive for the patient. Okay, these important factors of the ECG and some findings are very important. So please do read this topic and revise well. Those who are new to this channel, please do subscribe and share with your friends.